Good morning, good afternoon, good evening, everybody. And I'm delighted to welcome you to the second session of this joint IACRLRD, IACH webinar on preclinical and translational research aspects of hematological malignancies, including comparative research from animal models. So as you know, the aspect of comparative research on leukemia and related diseases led in 1960 the World Health Organization, WHO, to inaugurate the International Association for Comparative Research on Leukemia and Related Diseases, IACRLRD, and its symposia to take place at various sites around the world every 2 years. The comparative aspect brings together physicians, veterinarians, and scientists in basic research to promote research and to improve outcome in leukemia and related diseases worldwide. As part of the partnership between the IACRLRD and the International Academy for Clinical Hematology, IACH, we are pleased to invite you to participate to this webinar series. The second webinar is taking place today, entitled Mastoctocytosis from Dogs to Humans, and the speaker will be Professor Olivier Hermine in Paris. So Olivier Hermine, MD, PhD, is a professor of hematology at the University of Paris-Cité, head of the clinical department of hematology and National Reference Center on Mastocytosis at the Hôpital Necker Enfants Malades in Paris. He's also the head of a research group on physiopathology and treatment of hematological disorders at the Imagine Institute. He's the current member of the American Society of Hematology and active member of the Red Cell Committee. Olivier is a board member of the EBMT Lymphoma Working Party, the European Mantle Cell Network. He's a member of the Scientific and Administrative Committee and coordinator of the Mantle Cell Group of the French LISA, French Lymphoma Study Group, and of the International Retrovirology Association, HTLV1 and related viruses, including T-cell lymphoma. He's also co-founder and scientific director of the French CELAC Group on intestinal lymphoma. Olivier has been elected member of the French National Academy of Science, French National Academy of Pharmacy, and Belgium Royal Academy of Medicine. He teaches hematology, both basic and clinical, at different levels from undergraduate to MD and PhD. He's a board member of the Imagine Institute, co-author of more than 930 publications in prestigious international scientific journals. Olivier Hermine is a co-founder and scientific director of two biotechnologies, Inateris on monoclonal antibodies and Abescience on kinase inhibitor. With Abescience, he pioneered the development of the first kinase inhibitor in mastocytosis in dogs and cats. Overall, his research tries to understand and study mechanisms underlying several hematological malignancies and benign hematological disorders in humans and animals in order to improve care and develop targeted and immune therapy. I would like also to mention that I have been enjoying more than 35 years of collaboration and friendship with Olivier. Olivier, the floor is yours.
Thank you very much, Ali, and I'm pleased to be here today and thank Ali for his nice invitation and, as he said, friendship for the last 30 or 35 years. So today I will talk about mastocytosis from animals model to human disease, and I will focus on the physiopathology and treatment and what we can learn from animals model. So first, here it's my disclosures. I am a co-founder of AB Science, and a research grant from Novartis and Blueprint. So as you know, we can take advantage of basic science and drug development to understand human medicine. And also we can use animals model and particularly, and that I like, the natural model of disease that we can see in patients in veterinarian medicine. And the crosstalk between these four assets may help us to improve our knowledge and treatment of disease, both in humans, but also in animals. So here I would like to show you before that we have set up in France, because most of my work also will get related to what we have done in France to set up a network of mastocytosis in different parts of France, like that all patients can see a physician which is competent in mast cell diagnosis and treatment, no far further than 150 kilometers from his home. So what is mastocytosis? It's by definition, it's a group of rare and heterogeneous myeloid disorders, which is characterized by mast cell accumulation in various organs, including skin, GI tract, liver, bone marrow, and so on. It is considered as a myeloproliferative disorders because we know that mast cell originate from bone marrow, and usually we can classify the disease as aggressive versus indolent disease, and sometimes it is associated with another hematological disorders, including myelodysplastic syndrome, myeloproliferative disease, and eventually leukemia. The presentation of disease is quite heterogeneous, depending on the infiltration of mast cells in different tissues, but also on mediator released by mast cells in these different tissues. We are also used to split the disease into two parts. In one side, the children, in which disease occurs below the age of 2, and which is characterized usually by an abnormal and aggressive phenotype, but which regress at teenagehood. So for a long time, it has been thought that this disease is quite of a reactive disease, but not a clonal disease because of its regression features. In contrast, in adults, the disease occur in young adults, but also it may occur late in life. And usually it is a chronic disease with no aggressive features and which not regress. Never you see a regression of this. So it has been thinking that it was a clonal disease. And we have a rare disease, which is called mast cell leukemia and sarcoma with a rapid fatal outcome. So here it is a slide showing the overall presentation of mastocytosis. You can see here that the patient might experience some aggressive feature of mastocytosis, which is due to mast cell infiltration in various organs, including the bone marrow, the liver with cirrhosis and portal hypertension and ascites, and it can infiltrate the GI tract, inducing malabsorption and weight loss. Also, it can induce some lytic lesion, as you can see here, inducing bone fracture. So all of these aggressiveness features may classify the mastocytosis as aggressive. And on the left side of the screen, you see patients with what we call indolent mastocytosis, in which the disease is not characterized by accumulation of mast cells in different tissues, but more by release of mediators and cytokines from the mast cells. And this release of mediators include a lot of symptoms, including anaphylactic shock, including bone osteopenia and osteoporosis, leading also to bone fractures, and also the skin with skin rash, as you can see here, or involvement of the skin, as you can see here, with the maculopapular aspect of classical mastocytosis. What we have found, and I will come back later to that, is that this patient experience also some general symptoms like neurological defect with memory loss, cognitive dysfunction, depression, headache, sleep disturbances, and pain. And also they experience cardiovascular event, acute ones with syncope, dizziness, and palpitations. So what is interesting also to notify is that a patient with aggressive feature usually have less symptoms than the patient with not aggressive features, with symptoms are at the front line of the clinical presentation. So to make the diagnosis of mastocytosis, you need to have what we call the major findings, which is aggregate in the different tissues, like here you can see in the skin and here in the bone marrow, that we assess the presence of mast cell by the tryptase staining, which is specific of mast cells. And interestingly, these mast cells express the CD2 and the CD25 antigens, which are usually expressed in T cell, but not in a normal mast cell. So if you have aggregate mast cells which express CD2 and CD25, you are almost sure of the diagnosis of mastocytosis. And we need also some other criteria, and I will come back later to that. So because of this heterogeneity, the WHO has made a classification of patients, what we call the pure cutaneous mastocytosis, and depending on the clinical presentation, we classify them at maculopapular cutaneous mastocytosis, diffuse cutaneous mastocytosis, which occur mainly in children, and mastoma of the skin, which is a localized tumor. And then we have what we call the systemic mastocytosis, meaning that we have mast cells not only in the skin, but in other tissues. And we split this mastocytosis between indolent systemic mastocytosis, smoldering systemic mastocytosis, aggressive systemic mastocytosis, in which we do see organ dysfunctions, and also systemic mastocytosis with associated hematological neoplasms that we call HAN. And also we have mast cell leukemia and very rarely mast cell sarcoma. So what I did write in red here are the one what we call advanced mastocytosis, representing 10% of all mastocytosis, which are associated to the poor prognosis. In addition, as I said before, we can see some associated neoplasms in patients with mastocytosis, which include myelodysplastic syndrome, myeloproliferative disorders, and myeloproliferative dysplastic syndrome, including and CMML, which is quite frequent in association with mastocytosis. Very rarely we see lymphoid neoplasms, but they are not usually classified as associated neoplasms. So here, the stratification from the WHO is quite important, because you can see here that the patient with indolent mastocytosis has a similar life expectancy as the regular population. In contrast, patients with associated neoplasms or aggressive mastocytosis have a poor prognosis, and the one with leukemia and sarcoma are very poor. And this one has been confirmed in different studies. And here on the right side, it is the nice European studies showing that the patient with advanced mastocytosis have a poor prognosis, particularly the one with mast cell leukemia, mast cell sarcoma, and advanced and associated hematological neoplasms. So we have made a big study in the European mastocytosis network, and we have shown that the patient with systemic mastocytosis with HAN exhibit a poor prognosis, as you can see here when you compare to patients with no hematological malignancies. And when we split all systemic mastocytosis between non-advanced and advanced, you see in advanced, non-advanced mastocytosis, the fact to have an associated neoplasms is associated to the poor prognosis, as well as in patients with advanced systemic mastocytosis. And when we split in different groups, when you look at patients with advanced systemic mastocytosis, regardless the type of hematological neoplasms, which include myeloproliferative MDS and MDS-MPL, you can see there is no difference in terms of prognosis. In contrast, in non-advanced systemic mastocytosis, patients with myeloproliferative disorders are going very well, in contrast to patients with MDS and MDS-MPL, which exhibit similar phenotype of patients with no mastocytosis. So to make the diagnosis and subclassification of SM, you need first to assess the clinical symptoms, and particularly if you do see weight loss and splenomegaly, portal hypertension, ascites. In this case, you may suspect an aggressive mastocytosis. And then you may confirm by very simple blood tests, which include CBC to test for anemia and thrombocytopenia or neutropenia, and eventually for an associated hematological cytoplasm, particularly if you see a monocytosis or eosinophil. And biologically, you can see an elevation of tryptase, which is characteristic of mastocytosis. And depending on the level, you can also have some insight to see if it is aggressive or not aggressive. And if you have a low albumin level and high APL, you may suspect also an aggressive mastocytosis. And then you have to assess the diagnosis by doing a biopsy, and you will see the main criteria with the aggregate of mast cells in different tissue. You can assess the tryptase level, and you will see we assess some molecular biology, and I will come back to that. And then you can classify the patient if he has C findings or not, and then you can make the diagnosis of the different type of mastocytosis. So in the NCCN classification, you can see here that the diagnosis might include the presence of mast cells in the bone marrow or in the skin, and then you have to assess the phenotype by doing the CD25, CD2, and CD30 markers, which are atypical markers of mast cells. And so when you have this marker, you may suspect mastocytosis, and you may look for, I will come back to that, some KIT mutation. And you have look of C findings and B findings. C findings are associated to cytopenia and hepatomegaly with abnormal liver function. And then you can make your classification between mast cell leukemia, in which you have more than 20% mast cells during aspiration, aggressive systemic mastocytosis when you have 1 C findings, and indolent mastocytosis when you have no C findings. So now let's go back to the physiopathology of mastocytosis, which is very important to understand in order to find a treatment for this disease. So there is no animal models of mastocytosis, but very interestingly, in veterinarian medicine, in dogs and cats, mastocytosis is quite a frequent disease, and actually it's the most common cutaneous tumor in dogs, representing 20% of all tumors in the skin and the soft tissue of dogs. And usually in dogs and in cats, mastocytosis is associated to the poor prognosis with a life expectancy lower than 6 months in aggressive tumors. And very interestingly, in dogs, the pictures looks like what we do see in humans, patient with mast cell sarcoma. So aggressive disease. So it's quite interesting to look at this model to understand and to try to develop drugs in mastocytosis. So if I come back to the physiopathology, we know that mast cells come from CD34 positive progenitors in the bone marrow that go to differentiate toward the precursor, which is circulating in the peripheral blood. And very interestingly, in contrast to other hematological lineages, mast cell lineage express highly the KIT tyrosine kinase receptor. So in peripheral blood, the high KIT level precursors are present, usually they are CD34 negative and do not express yet the IgE receptor. And then in the peripheral tissues, depending on the microenvironment, they will differentiate in different kind and subtype of mast cells. So this one is a regular differentiation of mast cells, and we don't know yet whether or not there is some precursor with different features which may give rise to different type of mastocyte in the peripheral tissue, but we do think that this heterogeneity is more due to the environment in which the mast cell terminates their differentiation. But what is very important to note here is that it's the only lineages in which KIT is highly expressed along the differentiation towards the terminal differentiation. And this feature led to the idea that KIT mutation may induce mast cell accumulation. And actually, it has been found in the first paper in Nature Medicine in 2010, I think, that dogs exhibit some KIT mutation which are associated to mastocytosis. So come back from dog, we try to do and check for KIT mutation in humans. So what we did for more than 1,000 patients, we look at the KIT mutations. And KIT is a very long gene with 21 exons. But what we do find, and we found that regardless if the disease is indolent or aggressive, we find some mutation in the X16 mutation. And very interestingly, this mutation, particularly the S16V mutation, is present in 90% of the patient with mastocytosis. So we look to all genes, and we found very interestingly that in pediatric patients in which we are thinking that it was a reactive disease, we found also in 80% of the cases some mutation in the KIT gene, but not in the phosphotransferase domain of the receptor, but in the extracellular justamembrane domain of this receptor. And when we look at more and also a lot of dogs, we found exactly the same thing, but in dog, interestingly, the the mutation occur particularly like in pediatrics in extracellular domain of the KIT receptor. So you can see here, we have a disease in dogs, children, and adults, in which we found 85% KIT mutations, but in different locations. In adult, it's localized in the phosphotransferase domain, and in dog and in pediatric patient in the extracellular justamembrane domain. So all of these mutations induce a constitutive phosphorylation of the receptor to induce a signal transduction pathway. And interestingly, when we take from the peripheral blood mast cell precursor in patients with KIT mutation, we can induce the differentiation of this precursor in mast cells without adding any stem cell factor, which is a natural ligand of this receptor. In contrast, to do so with non-mutated KIT, you do need to add stem cell factor to get some mast cells in the tissue. So now we have this picture in which in pediatric we have a 75% of KIT mutation. And one of the main questions, because now we know it is a clonal disease, it was to understand why in some cases the disease regress and sometimes give rise to sarcoma like in dogs. So to make a long story short, first we have shown that the phosphotransferase mutation, the KIT S16 mutation, is not able to induce the transformation of fibroblasts in a semi-solid medium. In contrast, the juxtamembrane extracellular domain mutation of KIT is able to induce a transformation. And this one correlated with a different signal transduction pathway. In the phosphotransferase domain mutation occurring in adult, we do see activation of the JAK-STAT pathway, but very poorly the PI3 kinase AKT pathway, and very poorly also the MAP kinase pathway. In contrast, in the aggressive, in the pediatric mutation, we do see high activation of the PI3 kinase AKT pathway and MAP kinase pathway. And also, when we look at pediatric patients that regress at teenagehood, what we found is that the one with the extracellular domain, the aggressive mutation, transforming fibroblasts and inducing also PI3 kinase AKT and MAP kinase pathways, and this mutation induces the regression of the disease at the puberty. In contrast with the S16 mutation, the disease is persistent. So here we see that the mutations may determine the fate of the disease between aggressiveness and regression and in pediatric and adult patients. So we came to the idea that this regression may be due to short telomere and senescence induction. And we know that when cells have a short telomere, they die of senescence. But in some cases, if you have some mutation of P53 or P16, the cell will not die and they will increase the size of the telomere, even if there is no telomerase activity par homologue recombination at the short telomere. So Here, what we found, and to make a long story short also, is that in a pediatric patient in which you have a high activation of the MAP kinase pathway, we have shown first there is no telomerase activity, but telomere, when there are no telomerase activity, get protected by what we call sheltering protein, including TRF2. And we have shown that TRF2 is phosphorylated by MAP kinase P38 pathway, leading to the delocalization of TRF2 from the short telomere, inducing the senescence of the tumor. But in case of P16 or P53 mutation, we do see a recombination in the nuclear body between the short telomere, which allow the increased size of telomere, which explains the aggressiveness of the disease, because you induce a massive genomic instability. In contrast, in the adult mutation, you can see here we have a low activation of the MAP kinase pathway, so the TRF2 remain localized in the short telomere, and the telomere gets stabilized. And in this case, the disease is quite stable and with no induction of genomic instability. So then, because this mutation, we do see patients with aggressive mastocytosis, not sarcoma, but aggressive mastocytosis. How to explain this aggressiveness with these phosphotransferase domain mutations? And you can see here a lot of work has been done showing that in this patient with aggressiveness, although they do express the S16 mutations, they express additional mutation. And which one are these mutations? Are mutations that we do find in patients with clonal hematopoiesis and MDS and MPN, like TET2, SRSF2, ACLX1, RUNX1, JAK2, and so on. And interestingly, we do see that not only when you get this mutation, you get an aggressive disease, but depending on the type of the mutation, the prognosis may change in this patient. For example, here, when you have a no mutation, you see the prognosis is good, even in aggressive mutation, in aggressive mastocytosis. When you compare with one mutation or two mutations, you see the prognosis is quite bad in this patient. And also, it has been shown that mutation of SRSF2, ACLX1, and RUX1 are particularly aggressive mutation in a combination with a KIT S16 mutation associated to the poor prognosis, as you can see here in this patient. So the model is that when you have a clonal hematopoiesis mutation occurring in stem cells, if you add a KIT mutation, you may have exhibit some aggressive feature of mastocytosis. And depending on the mutation, the aggressiveness might be more important. For example, if you have SRSF2, ACLX1, or RUNX1 mutation. But this clonal hematopoiesis may give rise also to additional clonal hematopoiesis, and eventually that may transform in MDS, MPN, or MDS, MPN in this patient. So, and the KIT mutation may occur early or late during the development, and depending where this mutation occurs, the number of cells and the presentation of the additional hematological neoplasm may depend on where this mutation occur. And we know that when they occur with a SAR mutation here, the prognosis is quite poor. So the question is why and how this mutation of epigenetic related mutations, they may explain what the existing mutation became aggressive, whereas it think that it is not an aggressive mutation. So it's very difficult because we know when we change a mutation in SRSF2, ACLY1, or TET2 eventually, this mutation may have a lot of impact in the gene expression in the cell. So we don't know at which level KIT S16 mutation may synergize to induce the transformation and aggressiveness of the disease. So what we did in Necker Hospital, because we are in the pediatric environment, we take advantages of patients having a congenital mastocytosis with an additional phenotype to make some hypothesis of this additional mutation responsible of abnormal phenotype in this patient, if they may occur sporadically due to additional mutation. For example, if you have a SRSF2 or TET2 mutation, they may dysregulate the expression of some proteins, which may play a role in synergy with A16 mutation to induce the transformation. So I think it's very important to observe this phenotype. So here, it is an example. Now we have more example, but I will show you today only one. It is a young patient with aggressive mastocytosis, and he has a A16V mutation, the one we do find in adult patient associated to indolent mastocytosis, except if you have additional mutations. And here we sequence the whole genome of this patient, and we didn't find any additional mutation of that we call TET2 or SRF2. But this patient was interesting because he has what you call Greig syndrome, because he has a big head and he has 6 fingers. And this mutation is associated to mutation in the GLI3 repressor, which repress the hedgehog pathway, which is very important in the cell transformation and very important also in the stem cell renewal. So here we could show that the lack of a repressor of the hedgehog pathway may induce the proliferation of mast cell transduced with the KIT S16 mutant. When you have only the KIT S16 mutant, you see you have no proliferation of mast cells, but in the context of repression of the hedgehog pathway, if you reprime the repressor of the hedgehog pathway, you have a transformation. And interestingly, when we look at patients with aggressive mastocytosis, we found a downregulation of the expression of the GLI3R protein, meaning that this pathway is constitutively activated, probably by an epigenetic dysregulation, leading to downregulation of the expression of this repressor of the hedgehog pathway. And in mice model, it is interesting because we could show that this hedgehog activation might be a target of hedgehog pathway inhibitor like sonidegib, which is registered in carcinoma of the skin. So here, based on some very rare, unusual cases, we can make some hypotheses which explain the aggressiveness and open new avenue for new treatment in mastocytosis. So here, it is a summary of what I said just before, is that in the KIT mutation alone, you have no transformation. But in genetic disease in which you have mutation of the GLI3R receptor here, repressor here, you may see a constitutive activation of the hedgehog pathway, which synergize probably to the P3 kinase AKT pathway to induce proliferation. In adult patients, you see a downregulation of the GLI3R pathway, probably by epigenetic regulation. And interestingly, this pathway may induce the expression of BCL2, for example, which may increase the survival of these cells. So now let's move to the treatment of this of patient with mastocytosis. And what is very interesting, knowing the physiopathology of mast cells. Now, it is we have two kinds of the disease: the advanced disease, in which you have a reduction of life expectancy and organ failure. So in this case, what you want is to increase the overall survival of the patient. In contrast, in indolent disease, the life expectancy is normal, you have no organ failure, but you want to treat the symptom associated to mast cell release mediators. And this mast cell release may induce symptoms which may impair significantly the quality of life of the patient. So for the last 20 years, we have developed a lot of new therapeutics for aggressive mastocytosis, and we started with interferon and cladribine and stem cell transplantation. But we make a big advancement in the 15 to 20 when we targeted the KIT oncogene. So I will show you some development of that. So first, using KIT as a target in mastocytosis. And this one was very important because at this time, when we came with the idea to block KIT, people claim that KIT might not be a good druggable drug because we may impair the hematopoiesis, and also we may kill some mast cell, which may release some factors which may induce anaphylactic shock. So everybody was very scared to develop a KIT inhibitors because of this risk of impairment of hematopoiesis and anaphylactic shock. So what we did first, we tried to develop a specific KIT inhibitors to prevent any off-target effect, and we found a drug that we call masitinib, which is a typical kinase inhibitor which enters the pocket of the ATP binding of the KIT receptor. And you can see here, it's a quite selective KIT inhibitor. And interestingly, also, we developed this inhibitor because he was able to block the Fin-Lin Src kinases here as a low nanomolar concentration. And he blocked also the KIT receptor, which was very interesting, but he did not block the exon 17, the phosphotransferase domain mutation, the X16 mutation, but block very well the extracellular mutation that we do find in dog and in pediatric patients. And this kinase inhibitor was able to block the phosphorylation and the migration and activation of mast cells. And interestingly, as you can see here, before to go in clinics in patients, we started to treat dogs because dogs, as you see here, looks like humans. And interestingly, as you see here, we can induce the decrease of the phosphorylation of the KIT oncogene in mast cell line from dog tumors, as you can see here, and you see we induce the apoptosis of these cells in vitro. So we move from that to a natural model of mastocytosis, which is a dog mast cell sarcoma, in which we have a mutation of the extracellular domain. And you can see here something which is very interesting. First, you see these tumors, they are very aggressive, with a feature of necrosis and bleeding because mast cell release a lot of factors, including histamine, VEGF, and proteases, which induce this abnormal feature. But after 3 days of treatment, you see we do see a nice regression of mast cell activation with an improvement of the phenotype of these dogs. So you see the tumor change its features, it's less aggressive and less necrotic. And then you see after 18 days, the tumor disappear totally. So before this treatment, we have to cut the leg of the dogs and induce and give chemotherapy to improve a little bit the survival of this dog. But you can see here with the small pills, and after 18 days of treatment, the tumor disappeared totally without any side effect in these dogs. So based on this result, we moved to a phase 3 study in dogs. And interestingly, you can see here that in first-line therapy, you see an increase of the overall survival of the dogs with mastocytoma, and particularly the one with the extracellular mutation of KIT. Here you can see they improve significantly their survival when you compare to the placebo treatment. But interestingly, even in the wild-type tumors, you see that blocking KIT and probably also the Src kinase improve the prognosis of the dog. So based on this phase 3 study, as in humans, the drug gets registered in human in veterinarian medicine. So it was a proof of concept in the natural tumors that blocking KIT may improve significantly the prognosis of patients, which is dog here, with mast cell tumor. And then we take advantage of this dog model, which is natural model, to see what happened to the dogs who are not responding or relapsing. Very interestingly, you see when they do relapse in the placebo, in the treatment, you don't see any significant difference in terms of local recurrence between the placebo and the treatment. But in contrast, you see a nice reduction of metastasis in the treatment with the kinase inhibitor, suggesting that we may block metastasis with this compound. So we made some other experiments in rat, because we know rat exhibit some tumors, and this tumor may metastase. It's natural model, no treatment, nothing. After 2 years of surviving, some rat develop a tumor which metastase. And what we did, we treat for 2 years a rat, and as you can see here, we see in male a significant decrease of metastasis in this rat natural model of tumors, which is quite interesting because now in dogs and rats, we do see that the drug was able to reduce the occurrence of metastasis, suggesting that maybe mast cells may play a role in the development of metastasis. So it is possible that a mast cell play a role because we know that mast cells infiltrate tumors, and at this level, they may have a lot of function. They may be the bad boy by releasing tryptase and VEGF, which may allow some kind of angiogenesis to allow metastasis, but also they may block and regulate the immune response against the tumor, and also they may change the phenotype of the macrophages from M1 to M2 to favor metastasis of the tumor. So we did some experiments now in mice model, and we use a melanoma model of mice. And you can see here that all kinases inhibitor that was in the market at that time were not able to block the proliferation in vitro of melanoma, which was expecting because they are not dependent of kinases for their proliferation. But in the mice model, you can see here that when we treat the mice with masitinib, you can see we block the proliferation and we stop, and we slow down the proliferation of the mice. And something is very important to understand here is that when we look at the PFS, I mean, the time where the tumor starts to progress, it's quite similar. But the progression is very slow, which translates in improvement of the overall survival. And what is interesting also is that when we look at other kinases here, you see none of them did and show the same effect. So we don't know exactly what's going on here. And probably it's not only KIT, but it may be some other mechanisms of specificity of masitinib. And we look at the tumor of these animals, and you can see here that upon masitinib treatment, in contrast to imatinib, we see an induction of chemokine like CCL2 and 6CL10, and also we see an increased level of MCSF. And all of these three, two chemokines and MCSF, may induce the recruitment of macrophages within the vicinity of the tumor. So we made the hypothesis that what we did observe depend on mast cells, but also on macrophages. And what we did, we show here, for example, when we treat the mice with an anti-CSF1 blocking the MCSF receptor, you see, with masitinib, we see a decrease of the tumor, but we lose this effect when we remove macrophages with an antibody against MCSF. And same thing when we did same experiment with an antibody against CCR2. You can see here the same experiment. We lose the effect of masitinib, meaning that masitinib may block mast cells, but also block and change the phenotype of macrophages to induce this effect. And we see when we use clonodrat, which is a macrophages inhibitor, that we lose also the effect of masitinib. And interestingly, what we found in vitro, in ex vivo, is that masitinib is able to shift the phenotype of macrophages from M2 to M1, which is a protector against metastasis. But what we did find is that we see, because of the inflammation in M1, we see an increase of PDL1. And PDL1 may refrain the cure of the tumor, although we do see a decrease of the proliferation, an increase of the overall survival, but we cannot cure these mice because they cannot have a good T-cell response because of PDL1 expression. But here, when you do the combination of masitinib and PDL1, you see almost no progression and cure of these mice. So you see, based on what we have done on dogs, and we make some hypotheses on metastasis, and then we move to the mice model showing that some kinases inhibitor, they may induce the recruitment of macrophages, and this recruitment toward the M1 phenotype may protect the cells, and the addition of PDL1 may cure this model. So to validate this hypothesis in humans, we have treated patients with pancreatic cancer, which is a very difficult cancer to treat, and you can see here, we knew that, and everybody knows that pain is associated to the poor prognosis in pancreatic cancer. And we know that pain might be due to the release of some mediator by the mast cells within the tumors, and this pain might be a surrogate marker of mast cell activation. And when we treat mice, humans, with masitinib, you can see here we increase the overall survival only in the population which exhibits some pain, suggesting that targeting the mast cells may play a role to decrease the progression of this tumor. So then I will move to the treatment. We made the hypothesis also that downstream KIT, because as I told you, the masitinib is not able to block the S16 mutation, that the KIT mutation may induce some transduction pathway, including the P3 kinase AKT pathway. And interestingly, we know that they activate mTOR, and mTOR is the target of rapamycin. And interestingly, when we use a mice model here of KIT S16 mastocyte, you see that they proliferate as well as normal mast cells. And when you add rapamycin, you see no effect on the wild-type mastocyte. But in contrast, when we use rapamycin in the S16 mutant, you can see here a nice decrease of the proliferation of mast cells. So here we show that the oncogenic KIT S16 mutation is some kind of oncogene. We sensitize the cells to the mTOR inhibition. Actually, we don't know exactly what is the mechanism of this sensitization, but we're working on to understand. And when we translate that to humans, you can see here that we improve the overall survival of patients with advanced mastocytosis treated by mTOR inhibitor, as you can see here, with something like 20% complete response and 50% overall response rate, with an improvement of overall survival to 11 months. But it's not a great improvement, but it was some kind of an additional example of blocking KIT or signaling pathway downstream that may improve mastocytosis. And then we move to blocking the A16 mutation, first with the midostaurin, which is what we call a dirty kinase inhibitor, which blocks virtually most of the kinases, and with a quite low IC50 to 2.9 nanomolar to block the A16 mutation. But here, with this kinase inhibitor, we may expect some toxicity and a problem of tolerability because this is the dirty kinase inhibitor. But in fact, and surprisingly, it was quite well tolerated, except at the digestive tract level. But you can see here, for the first time, we do see that aggressive patients improve significantly their prognosis, and also the patient with mast cell leukemia with an overall survival, median overall survival at 1 year. And before, remember, these patients were all dead at 3 months. And same thing for the associated hematological neoplasm. You do see an improvement of the prognosis of these patients. So this one was a very good example that blocking KIT, eventually additional mutation, may improve the prognosis. But as you can see here, the overall response was only something like 60%, but very few patients, 16%, exhibit complete response. And in addition, the patient with a mutation associated to the poor prognosis, the SRSF2, XLX1, and ROX1, were also associated to the poor prognosis, as you can see here. So it was not the end of the story. So then we move to the second generation of KIT inhibitors, which is avapritinib, which is a block to block specifically the A16 mutation at the very low IC50 or 0.129 nanomolar. And you can see here that the response rate was quite high with most of the patients decrease significantly the bone marrow infiltration, and the serum tryptase goes down, and the spleen size volume goes down also, and you see a reduction of the KIT A16 mutation in the peripheral blood by digital PCR analysis. So you can see here that the drug is able to induce a massive reduction of mast cell infiltration, which translates obviously in an improvement of the overall survival in patients with aggressive mastocytosis, but also in mast cell leukemia, and also in patients with associated hematological malignancies. And it's better when you use it in first line than in second line. So here we do see that a massive transformation of the prognosis of the patients by blocking the A16 mutation. But interestingly, in these studies, the patient may have more than 50,000 platelet counts to prevent any kind of thrombocytopenia and hemorrhage. But we know that thrombocytopenia is associated with poor prognosis with patients with MDS. But here, if you have no poor prognosis features like a thrombocytopenia, you see the overall survival is quite spectacular. And in this study, also 30% of the patients exhibit complete response, no more mast cells in the body, but still 70% have mast cells. And if you block and stop the drugs, you see a relapse of the disease quite rapidly. But in the real life study, you can see here that avapritinib improves significantly overall survival when you compare to patients who did not receive avapritinib but other best care treatment. And interestingly, when we look at the associated hematologic neoplasm in these patients, we see here that the monocyte count goes down in patients with CMML, and the patient with hypereosinophilia, you see also a reduction of the eosinophil number. But this one was interesting because you see that eosinophils are associated with a poor prognosis in patients with mastocytosis, but was quite surprising because, as I told you before, the patients with CMML, for example, do not express KIT mutation, and also for eosinophils. So it means that the hypothesis is that mast cells in the bone marrow, they may express some cytokines, which may induce the proliferation of monocyte or eosinophils. And if you treat this patient with KIT inhibition, like here with avapritinib, you may block the production of cytokine, and this blocking of cytokine may reduce the proliferation of monocyte and eosinophils. And as you can see here, we have demonstrated that in the bone marrow of patients, for example, with hypereosinophilia, we do see around mast cell aggregates, eosinophils in the bone marrow of this patient, which express IL-5 and which may target IL-5 receptor in eosinophil, which may explain why the eosinophils are proliferating in this group of patients. So something which is very important when we treat patients, and mostly the one with KIT existing mutation, you see when the treatment is working and when you see a decrease of the tumor burden assessed by digital PCR in the peripheral blood, you see here that the decrease of the KIT A16 mutation burden is associated to a good prognosis when you compare to patients with a less of 25% reduction. And when you look at this patient, it's interesting also to see the one with a poor mutation. You see sometimes an increase of the clones with the SRSF2 or RUNX1 mutation. So meaning that we have to assess and follow this patient with NGS technology to see if the burden of additional mutation increase or decrease in the same times as the mast cell burden. So how to improve this result? And something which was very interesting, we look at BCL2 expression because BCL2 may prevent cell death. And we know that when we stop midostaurin or eventually when we stop avapritinib, even if patients have very good response, they go back because the cells are not dead. They stop to proliferate, they stop to be activated, but they don't die. And you can see here, when you look at the prognosis of patients with mastocytosis, the patient with mast cell leukemia or mast cell sarcoma do express highly BCL2, which may prevent their death. And interestingly, when we treat, for example, patients with midostaurin, you see a reduction of mast cell infiltration, but still the same expression of BCL2 in this patient before and after treatment. So we make the hypothesis that BCL2 may induce the survival of these tumors. So we look at the anti-apoptotic proteins, which include MCL1, BCL-XL, and BCL2. And interestingly, in both cases, when you treat cells with avapritinib or midostaurin, you see a downregulation of MCL1 and BCL-XL. But BCL2 remain at the same level. So meaning that the cells which are surviving before because the expression of MCL1 and BCL-XL and BCL2 cannot survive and can survive only because of BCL2 after treatment with avapritinib and midostaurin. So this one led us to do some synergistic studies, and we have shown here when we use a low dose of avapritinib or low dose of midostaurin in A16 mutant cell lines, you can see depending on the dose of venetoclax that we add, which block BCL2, we see a killing and the stop of the proliferation of the cells. So we show here that by downregulating MCL1 and BCL-XL, KIT inhibition may induce the sensitivity to BCL2 inhibition, which is the only anti-apoptotic factor that allows the cells to survive. And here you can see in patients who are refractory to midostaurin here, the addition of venetoclax induces complete response in this patient. And same thing here, a patient with mast cell aggressive mastocytosis plus associated neoplasm, which is leukemia here. The combination of venetoclax, midostaurin, and azacitidine induce a massive reduction of both the leukemic component, but also the mast cell component in this case. So now we will start a protocol by adding to KIT inhibitors venetoclax to induce a better and profound response in this patient. Bone marrow transplantation may be an option in this patient, and you can see here that the overall survival is good and better when you use myeloablative conditioning regimen, you can see here. But this one has been observed before we get kinase inhibitor. So in patients who are progressive and refractory to kinase inhibition, you may use bone marrow transplantation. And this publication is quite interesting because it showed that in case of relapse of mastocytosis after bone marrow transplantation, the use of DLI may induce a graft versus leukemic effect to induce the disappearance of the mast cell proliferation. So mastocyte might be a target of graft versus leukemia, which was something that we questioned before. But here we show that in some cases it might occur. So one of the questions which is quite difficult also is to try to understand when you have a patient with an additional hematological neoplasms, how to treat this patient. Should we treat first mastocytosis and to see if the cytopenia and the performance status of the patient improve, or should we treat first the associated hematological neoplasm to see if we have an improvement of the cytopenia and the performance status? So to try to decide between the two decisions, probably the patient with the major findings, with a high level of KIT A16 burden, with a high level of tryptase, with a high level of infiltration of the bone marrow, you should treat first the mast cell component and then to see what happened to the cytopenia, for example. And eventually, you may add treatment to treat the additional hematological neoplasms. In contrast, if you have a low burden of mast cells with low tryptase level, low A16 burden, you may start first by treating the associated hematological neoplasm, and you see what's going on the performance status of the patient and of the cytopenia, and you may add secondary KIT inhibitors. And something that we treat this patient, you have to follow something which is very important, because when we treat the patient with only aggressive mastocytosis with no more additional mutation, you can see here, we see a reduction of the A16 burden, meaning that we reduce the component of mast cells. And we can see that also in patients with associated neoplasms, you see the reduction of the A16, eventually of the additional mutation. But at one point, you see an increase of the additional mutation, probably because it is the associated neoplasms, the clonal hematopoiesis, which increase when you reduce the mast cell component. And you have the risk here to develop leukemia or MDS. What is important here? You should consider at this time, when you have a low burden of mast cells, but you see an increase of the clonal hematopoiesis mutations, to perform allo stem cell transplantation to cure the patient. And eventually, sometimes you see the appearance of secondary clones with P53 mutation, for example, or NRAS mutation. And in this case, you have to go fast to do bone marrow transplantation because probably this patient will transform in leukemia quite rapidly. So I think now it's important, to look at the S16 burden and to look at the NGS additional mutation to see what is the evolution of the different clones upon treatment to perform the good decision to perform a bone marrow transplantation when you see these bad clones appearing upon treatment. So you see in advanced mastocytosis, you have to look at the poor prognosis mutation and look at the response, and you treat this patient first with avapritinib or midostaurin. And if you see a nice reduction of everything, if you have no bad mutation, you can follow the patient, because now with a long follow-up, some patients are still in partial or complete response with a very good quality of life. But if you see an increase of the poor prognosis mutation, or if at baseline you have a poor prognosis mutation, you should consider quite rapidly a bone marrow transplantation if you have a good donor and a patient in a good performance status, which is often possible after treatment of the mastocytosis. So I will finish in the 5 minutes that that's left to talk a little bit of indolent disease. Indolent disease It's, as I said, the main goal is to block mast cell activation. And we make a very good survey a long time ago showing that the patient with mastocytosis experience and have a perception of high disability because of the symptoms. And you can see here between 20 to 25% of the patient seems and feel that they are handicapped because of the symptoms of the disease. And what is very interesting is not the one that the physician do see, but the one the patient perceive. For example, you see the psychological impact, the asthenia, the fatigue, the bone pain are the most, and the cognitive dysfunction and the depression are the symptoms which are impairing the most the quality of life of the patient. And we assess that in patients, and we show that this patient exhibit depression, cognitive dysfunction, and anxiety that we call alexithymia, because they don't know why they experience this anxiety. And we strongly believe it is due to the mast cell activation. And actually, we have shown that patients with mastocytosis have, by IRM-ASL, an hyperactivity of the central gray nuclei, because to compensate a low metabolism that they have in their brain. And the patient with depression have a low activity of the cingulate, which is known to be associated to depression. So we can correlate the clinical symptoms and the ASL, IRM in this patient. And we do think it is due to the mast cell activation. We do first release histamine, which reduces the blood flow in the brain, which may impair cognitive function and metabolism of the brain. But also, in addition, we have shown that the mast cells may induce the degradation of the tryptophan, which leads to the development of and production of mediators which are toxic for the cognitive function. And in addition, because tryptophan is the substrate of the THP1 enzyme to transform in serotonin, this patient has a low serotonin level and they are depressed. So we can explain why this patient exhibit and experience a lot of neurological symptoms. So how to improve these patients? So we have first show that IgE may bind to mast cells to increase their survival and their activity, even if there is no antigen. And mostly in the context of A16 mutation in underlying mastocytosis, IgE may activate spontaneously mast cells. So we treat patients with anti-IgE, and what we did find, we found that this patient have a strong reduction of their symptoms, which was a very good thing. No infiltration decrease, but strong decrease of mast cell activation symptoms, including the one associated to depression and cognitive dysfunction. And in this context, because we are able to block mast cell activation with the masitinib I told you before, by blocking FIN and BIN, we make the hypothesis that blocking mast cell activation without killing them, because we don't block KIT, because it is associated to the A16 mutation and the drug doesn't work. We did see in the phase 3 study that we published in the Lancet 10 years ago that we are able to block and to improve depression and cognitive dysfunction in this patient by blocking mastocyte, which is very important findings because it shows that mast cell activation may have some consequences to the brain functioning. And if you block mast cell activation, you may improve depression and cognitive dysfunction in this patient. And you can see here, for example, the ASL of a patient with a poor metabolism before treatment. After treatment, you see a normalization of the metabolism of his brain, and this patient recover a full cognitive function, whereas before he was so tired he could not work anymore. And then to finish, we are moved to KIT A16 mutant inhibitors with the avapritinib, which is quite selective and safe with a low dose of the treatment. And you can see here that we improve significantly all parameters of quality of life in this patient. So now we have a good drugs to block mast cell activation, and here also mast cell infiltration, which may decrease the skin involvement. So to conclude, mastocytosis is easy to make the diagnosis, and in case of aggressiveness with cytopenia, now we have drugs with midostaurin and avapritinib that we may add venetoclax to improve the deepness of the response. In case of non-aggressive disease, we have to look at the symptoms of the patient. If they don't feel anything, you should just watch and wait the patient. In case of handicap, you may use the classical antihistaminic, anti-H1, H2, and so on. And in case of improvement, no further treatment is needed. And otherwise, you may start kinase inhibitor. So I will finish here to thank my collaborator, in which we have done all of this work for the last 20 years. And as you can see, it was a very nice model in which we switched between dogs and mice and rats and humans to improve the knowledge and treatment of mastocytosis. So now I'm happy to respond to your questions. Thank you very much.
Thank you very much, Olivier, for this wonderful and comprehensive presentation from the bench to preclinical animal models, including natural models in dogs and cats, to the bedside. We are a bit late, so maybe a couple of questions only. So the first one, I have it from Vaidian. Thank you for great presentation on very interesting topic. My question is related to the cell-based therapy in mastocytosis. Is it possible to use KIT as a potential target for CAR T-cell therapy in experimental model of mastocytosis?
I think it's a very interesting question, but there is two caveats to use CAR T-cells against KIT. The first one is that KIT is a multiple target, which is expressed, for example, in stem cells, in progenitors. So we may expect to see cytopenia if you use CAR T-cells against KIT. And probably also if the CAR T are activated in the bone marrow, they will produce a lot of cytokines, and you may see cytopenia exactly as we do see for CD19. But here we may see some profound cytopenia. And the second caveat is that when you have a X16 mutation, it's very interesting to explain why you say I show you that the signal transduction pathway is not the same when you have extracellular domain mutation and phosphokinase domain mutation, the X16 mutation. And when you have the X16 mutation, the receptor usually remain inside the cells. So there's a very, very low expression of KIT in mastocytosis with X16 mutation. You can induce the expression of this KIT by blocking X16 mutation, but it is some kind of a caveat, and the selectivity between normal and abnormal cell will not work. I know there is a development of an antibody which is changed to induce ADCC of KIT positive cells, but we don't know about the hematopoiesis. So KIT, I think, is not a good target for CAR T-cell. We may use, for example, CD30 because it expresses abnormally in mastocytosis, and we know that there is CAR T-cell development in anaplastic CD30 positive T-cell lymphoma, so it might be used in mastocytosis when you have a high level of CD30 expression.
The last question would be from Yun-Fan Yang. In systemic mastocytosis with associated hematological neoplasm, in which cells are c-KIT mutation present? Do they include tumor cells other than mast cells? And do KIT inhibitors kill tumor cells other than mast cells?
I think it's also a very good question. And what we may see, as I said before, KIT may occur very early during the development. So in this case, all cells, they may express the KIT mutant. But as you know, like monocytes, for example, or eosinophils, or eventually neutrophils, do not express the KIT receptor. They may bear the mutation at the DNA level, but the KIT itself is not expressed because, as I told you, the only lineage in which you have a KIT expression all along the differentiation is the mast cells. So probably, even if you have the mutation in the monocyte component or eosinophil component, or even in stem cells, you will not have an impact directly when you block the KIT mutant because the receptor is not expressed. But as I showed you before, in some cases, because of the production of cytokines by the mast cell component, which express KIT, you may block some cytokines, which may induce proliferation of monocyte or proliferation of eosinophils like IL-5, as we have shown before. So this one is a complex network, and we know that inflammatory context, cytokine production by mast cells, they may select some additional clone. And if we do block the KIT-16, you block this inflammatory cytokine, and you may see a decrease of the HN component. But usually, you have to treat the HN component as it is done usually. For example, with JAK2 inhibition, if it is a classical myeloproliferative JAK2 myeloproliferative disorders, you may use 5-acetidine in case of TET2 mutation and MDS and so on, or eventually high-dose chemotherapy plus midostaurin in case of KIT mutation with mastocytosis or aggressive or not association.
So thank you very much, Professor Hermine, for this wonderful presentation. Thank you all for your attention, and see you soon for another webinar. And have a nice evening.
And have a good evening, morning, and day, depending where you are. Bye-bye.
Bye-bye.